Moving forward to our next session today, Fireside Chat, Interaction of Women's Health and Technology. This session will be moderated by Dr. Julia Finkelstein from Cornell University in discussion with Dr. Bharati Kulkarni, Director, National Institute of Nutrition, Dr. Shobha Sudarshan, Nodal Officer, Maternal Health BBMP, Dr. Shantanu Pathak, Founder, Doto Health. To introduce our moderator, I would like to invite Dr. Tony Raj on stage.
Good morning, everyone. I take this opportunity to warmly welcome Dr. Bharati Kulkarni, Director of the National Institute of Nutrition from Hyderabad. Thank you, ma'am, for accepting our invitation and joining us for this fireside chat. I'd also like to thank Dr. Shobha Sudarshan for joining us. So good morning and welcome, ma'am. I know you've been working and interacting with St. John's for several years now, but thank you for your time this morning. And we'd like to thank Dr. Shanthanu as well. Now, to introduce Dr. Julia, she's here. Wonderful. Uh, I've known Julia for over 15 years. From when she was a postdoc, but I'll give you a brief about her. I've seen her journey and it's been wonderful. Dr. Julia Finkelstein is the Associate Professor in the Division of Nutritional Sciences at Cornell and in the Division of Epidemiology, Department of Population Science, Health Sciences at the Bengaluru College. I'm also Associate Professor at the Division of Nutrition at St. John's Research Institute as an engineer. She is the Director of the Maternal and Child Nutrition Program and serves as the Co-Director at the Cornell University Center for Precision Nutrition and Health, and the Director of the Associate Cochrane Center at Cornell. Dr. Finkelstein is a Program Director of the NICHD, signed up the Maternal and Child Nutrition Training Grant, the longest standing training program devoted to maternal and child nutrition. She also co-leads the clinical core of the NIH Center for Point of Care Diagnostics, Infection and Cancer, what we call PORTENT, and as I mentioned, is the adjunct faculty here for 7 years, St. John's Research Institute. Dr. Finkelstein is an epidemiologist with expertise in one-carbon metabolism, preconception nutrition, and maternal and child, and the design of randomized controlled trials and cohort studies in high-risk obstetric and pediatric populations in clinical and community settings. The lab focuses on one-carbon metabolism in women's health across the lifespan to develop interventions in clinical and in World Health Organization guidelines to improve health of women and children. So our focus has been mainly on women and children. Over 2 decades of our experience of research and academic leadership roles at leading institutions on and off and WHO specialized in nutrition and epidemiology. The career spans international work, clinical research, and professional. Welcome, Julia. I'll let you introduce each of our panelists. And,
Thank you so much, Tony. Good morning, everyone. I'm really honored to be here. And we'll try to keep to time because I know we have a photo coming after this. We'd love the fireside chat to be interactive, so we have plenty of time for conversations as well. So as you all know, PORTENT focuses on 3 core areas: nutrition, infection, and cancer, and with an ultimate goal of impacting and improving the health of populations from individual to the community to the populations who rely on them. We also have some cross-cutting themes. So women's health as we know cross-cutting themes, and for the conversations that ensue, women's health we're approaching as a life cycle, lifespan approach. So women's health from adolescent nutrition through women's health for women's sake, as well as for beyond, for between and beyond. So from preconception, pregnancy, postpartum, and beyond, really thinking holistically about women's health at the center for pregnancy. And we're also, of course, interested in specific health conditions that relate to women's health. We're extremely passionate and important bringing together academic, government, private sector partnerships, and that's why we're here in person celebrating today. And really to take innovations that translate into care outcomes to improve health. And I'm really honored today to welcome 3 experts in women's health from research, government, and private sector. Dr. Kulkarni, Shanthanu. And we're really excited to share perspectives on women's health and technology. I will first introduce each person and to invite you to join me here on the couch. We have some handheld mics, hopefully they'll be able to walk through as we join the conversations. So I'll introduce you properly by one, and then we'll start with some visual questions and those in the audience, please don't hesitate to jump in. So I'm honored to welcome Dr. Bharati to the stage. Dr. Bharati is a physician and scientist with specialization in pediatrics in the University of Pune in India and Johns Hopkins Medical School. She also has a PhD in Queen's University of Technology in Australia. As you all know, Dr. Bharati has extensive experience leading nutrition research and policy as a scientist at ICMOMN, and she's led in her position for more than 20 years. She recently served as the position of head of the Division of Reproductive and Child Health and Nutrition at ICMOMN Delhi. We're really delighted to welcome her back to serve as the director of the National Institute of Nutrition. She's led a number of large-scale clinical research as well as community efforts, which is directly from policy to improve women's health and child health. She's received a number of research grants from prestigious organizations across the globe, authored more than 130 publications in 100 journals, and received a number of prestigious awards. And she is also a fellow of the National Academy of Sciences region. Standing from keep it short. See, that's a really prestigious guest. I'm honored to welcome Dr. Shobha. Dr. Shobha is a senior specialist with extensive experience in maternal homes and maternal hospitals. She currently serves as the Family Welfare Officer and Maternal Health Officer for BBMP Health Department here in Bengaluru in the government health system, where she has served the position for more than 27 years. Dr. Shobha also heads district quality assurance and is the Nodal officer for a number of key government programs relating to maternal and child health. And she has been honored with the prestigious Award in 2014 for Vice Doctor and in 2022 for exemplary service as the COVID. So, last but certainly not least, I'm delighted to welcome Dr. Shanthanu Pathak to the stage. Dr. Pathak has a PhD in women's health from IIT Bombay. He is a passionate social entrepreneur working with the mission of creating equal and personalized healthcare opportunities for women. His ventures, Care Mother and Doto Health, are offering innovative digital solutions for healthcare providers and women in India and developing countries. Please, we're a friendly group. Shantanu has been awarded a number of prestigious awards, including the President of India's Innovation Scholar Award in 2015, and including 15 stays in the President's House, Google SMB Hero Award, and Top 10 Innovator by MIT, DST, and Martin. He's also been awarded the Emerging Leader Award by the School Foundation, Stanford Impact #1 Fetal and Maternal Award in 2023, and HIEX World Health Assembly Talk 2024-2025. Care Mother's innovative digital solutions, which we'll hear about in just a few moments, addresses high-risk pregnancy management, fetal and labor monitoring, and newborn care. Care Mother has impacted and that has reached more than 500,000 pregnancies in the last 5 years alone, mostly in India, as well as in other nations, including those across South Asia and Eastern South. Along his journey, he has also been associated with Nanobio's lab, IIT Bombay, and new problem statements in maternal health and cancer care, and is working to establish India's first women's health center. Welcome. Now I'm going to seamlessly transition to joining you on the couch for informal conversation. I'll switch over hopefully in just a second. Well, again, please join me in welcoming our prestigious panel to the floor. We'll do our best. This is a fireside chat, so you can imagine we're relaxing at home and tea. And the first question that we have is for Dr. Bharati. So Dr. Bharati, as everyone here knows, ICMR and National Institute of Nutrition here in India has really been a leader in the space of women's health and technology, and really, I think, serves as a model for government research partnerships. We'd love to hear your thoughts and perspectives on what are the next steps in terms of the priorities for point of care diagnostics or in the space of women's health and technology.
Thank you, Julia, and I take this opportunity to thank Cornell and St. John's Research Institute, this collaborative PORTENT Center for inviting me to this very exciting event. It is a great learning experience, and I get to interact. So in terms of women health and priorities for point of care diagnostics, anemia continues to be a recalcitrant problem in India. We have an ongoing anemia control program for almost 5 decades, but it still remains a big challenge. So going towards precision nutrition, identifying causes of anemia remains important. And although our anemia control programs revolve around iron folate supplementation, we know that iron deficiency contributes to only 50% of anemia. So identifying iron deficiency is important for having impactful iron folate supplementation, which is targeted towards those who need it. At the same time, not giving it to people who don't need it, where there can be some adverse effects. So I would like to take this opportunity to thank the company for transferring the ferritin technology, and ICMR is very pleased to take it forward in terms of identifying manufacturers who can do indigenous manufacturing. And that is the way to go forward to make it available to at scale and to the women in the remotest corner of the country where this will be very, very useful. So apart from that, there are like efforts for non-invasive hemoglobin estimation, because we know that when we have to test, treat and track, we need repeat measurements, and having non-invasive solution for testing is going to take it in a big way. So these are some of the, apart from that, I think there are multiple diagnostics which are under development by multiple groups. For example, ultrasound, which is essential during pregnancy monitoring, is not available to majority of women in the remote corners of the country. So there are efforts ongoing on making these tools available. Then there are multiple other challenges related to non-communicable diseases, which are going to be a big threat for the public health in India. And there are efforts ongoing for point of care tests for hemoglobin, HbA1c, and other indicators. So I think there we see a big role of this program.
Wonderful. And you touched on this, but as a follow-up, how do you see NIN and CMO in terms of scaling up and implementing such promising technologies?
Thank you for this question. Indian Council of Medical Research is very committed to help the government in making technologies affordable and accessible. So there are a number of initiatives. I think some of you may be knowing that ICMR, under the guidance of Niti Aayog, has launched MedTechnical. So where there is hand-holding support for the innovators, right from clinical validation till the product commercialization. We have, ICMR has also launched an initiative called Patent Mitra, to support the innovators in regulatory aspects. Uh, Apart from that, we have 27 institutes across the country, ICMR, National Institute of Nutrition being one of them. And the scientists at ICMR institutes, including ICMR and I, can help the validation of the technologies and also implementation research, which is extremely important for identifying the challenges and developing the models for scaling up and then showing it to the government, then how can it be optimally scaled up. So I think in this, we feel that we can make an improvement.
Thank you so much, Dr. Bharati. Dr. Shobha, the next question is for you. What do you see as some key challenges to integrating some of the point of care diagnostics into the clinical workforce and current healthcare systems here in India?
Thank you, St. John's Research Institute, for this opportunity. And I would like to say that the government has gone a way forward. It's like earlier, people we were losing is mainly because of anemia and then not reaching to the hospitals and so many things. But now it has improved a lot with the technologies. As and when the new technologies come and they incorporate and see that the public takes it up, and in the hospitals also we have the latest equipments, and then to reach out to the public, I mean to the women who are unreachable or who cannot come to the hospitals. So we have the doorstep. So that is like where we have the ASHA or the health workers who can reach out, and they're coming out with non-invasive techniques and other things like taking a blood sample. They require a permission, and the people don't do the follow-up and so many things. So in that way, it has come back like with the help of the link workers and ASHAs who can reach to the point of care, like to the doorsteps and to do that. Second thing is a lot of equipments which has come in as in a handy, like a strips, like methods where we can just with one drop of thing and with the hemoglobinometers and all that. So even if they're just walking into the workplace or anything, they can just get it done and then get themselves screened and do the follow-up. So in that way, we can prevent a lot of maternal deaths and other things. Like at least in the pregnant women, what we are doing is the monthly screening we have done. And so it's almost come down the maternal deaths, especially in Karnataka, which was 108 just 2 years ago, it's come down to 69 now. So that is a big challenge and which we have achieved.
That's incredible. Congratulations for this impressive body of work. We are really deeply committed to training the next generation of leaders in the field. How can we help to support training healthcare workers in terms of using point of care diagnostic devices or interpreting, integrating them into the system? Are there any training gaps that might be able to address through PORTENT SJRI professionals?
Yeah, I think the most important is the IEC. That is the most you communicate and make it aware to the people and show it how important. But only thing is that PCP Entity Act comes in a role in a pregnant women. But then if you justify those things, I think that will be a helpful thing. And incorporating with the partnerships and even the government to move in with and it is open to everything, I think then we can reach out to the public. Otherwise, if we are just tight enough and then not approachable and nothing, I think we will not help out. So it is just an open discussions, incorporate, find out the facts and figures and everything, and how helpful it is to the public. And then it is, and nowadays when we have the IAS officers who are heading our administrative, I think most of them are young and open to it, and they allow the discussions and other thing, and we give a trial. And I think a lot of partners have opened in and come in. The NGOs have come in and then they're trying to help out. And I think we have to move in those ways to move to reach out. Otherwise, being in the old system, it will not help us.
Thank you so much. Dr. Shanthanu, can you keep that one? So, because we're going to have questions. Okay. So, Dr. Shantanu, tell us a little bit more about your products and what inspired you to work on such other solutions.
Thank you for having me here as a innovator among many distinguished doctors and many women. And I feel proud to be in the panel where men are minorities. That also represents the importance that if more men has to work on the women's health aspect. Um, so just quick brief on what we do. Basically, we enable healthcare providers with digital and medtech technologies to serve pregnant women. We have a point of care last mile care kit, which helps last mile care workers to early identify high-risk pregnancies, triage them to a higher facility with a complete continuum care. So it's a point of care devices for essential checkups as well as the digital platform which enables triaging right from village level till the higher facility. So that's how we started. But when we reached the facility level, we realized that the focus on anemia somewhere reduced the focus on fetal health and how we can enhance. And we got this problem statement from doctors, and we also introduced digital portable wireless fetal monitoring solutions, which now enables the non-stress test at remotest part, whether it is village or even at the facility, as well as a comprehensive labor and birthing monitoring system, which basically covers vitals of the mother, fetal understanding, and also documenting all the components, the autograph, and the handover summary, etc. So what we have reached now as a journey in last 6 years is basically a continuum of care, right from first antenatal checkup coverage till the labor and birthing room to assure that. That's it. Thank you.
Thank you. And can you describe some of the key challenges that you faced as a startup company innovating assessments?
Well, getting into a labor room itself was a big challenge for me, and a lot of things were like I would have, naturally some of women colleagues who would go into labor room, understand, test the device, come out, give an understanding. So that wasn't the first hand experience, and best friend and guide in this scenario was my mother, with whom I could speak and learn as much as possible and discuss these issues. Naturally, then, I got few doctors who really helped in understanding. The conversation got more comfortable, but I think we talked about design, so the biggest issue was understanding the pain or the challenges from the mother's aspect. What is happening there, where you can't imagine. And interestingly, not a single person in our team that time was married or having a baby also. So it was difficult challenge from one end. The second end, as an innovator, was also learning public health system. I think one of the biggest learning for me was to unlearn engineering for a while, learn public health, what it takes to introduce a product into the system, or um, how things work. That was the biggest challenge to learn. And then, the journey continues to improve your learnings and challenges every time. And then it is the
Yeah. Two is this thing, even the latest technology to introduce into our system. In Bangalore, BBMP, that is the government institutions, we cater to a deliveries of 1,500 deliveries per month. So what happens is we have about 40 gynecologists, but still the load of deliveries in the hospitals, it is like people just walk in, or sometimes the checkup would be done in somewhere else and they would walk into the hospital which is close by to their parents' house, or somebody would, by the word of mouth, they say, no, this doctor would see it better, and with the approachability and the care is very good in this hospital. So they would walk into that hospital. It's just like without any registration or anything. But now the technologies have improved, and what he was telling about is the called as the Gen 3 machine, which has got all the components. Like as soon as the lady enters in, we connect it with the thing, and the BP gets recorded. The fetal heart monitoring is done, and the beep sound also alerts. So it's like the staff nurse who's the skilled midwife, which is there in the labor room. can be doing the other work also, and the beep sound can alarm us and say that something is going wrong or something, and they can identify and shift the patient to the tertiary care. So those kind of a thing. So all this kind of an equipment is supplied to our basic facilities, which just like a small maternity homes or anything. But then the staff nurse, I found the challenge was they were not ready to use the machine because they felt that owning the machine and then monitoring the machine, and then lot of excuses were coming in from the staff nurses, because I started monitoring like a daily dashboard, like how many people they could do it. And then there were stages where the pregnant women, as soon as they come, they just put in the NST machine and just check the fetal heart rate. Oh, the baby is fine, and they would just remove it and then they will move it out. It was never the full thing, like till delivery or after the delivery for at least 2 hours, we monitor the patients in the ward. So that way the continuity was not there. So I started tracking, and more the education was needed, and said, this is a handy machine. You're saving a mother by just doing it at this thing. So then they started, and then we also have to be disciplined and keep monitoring. And it's just then give a high profile machine or a high end machine or something. They would just say, no, no, I am used to this, and I think I am better off and more experience to give the thing. And we also saw that after the delivery, they used to sit and mark in the case sheets. But then we said everything is recorded here. And then after that, repeated monitoring and nothing. Now we see that they are all recording it. And since I have the admin log and I have can see the patients, how many people they had done it at the ANC level or during the delivery and postpartum. So those kind of a thing. Now all the nurses are thing. When I go for the inspections in the mornings to the hospitals, I just go stand in front of the machine and just check it. Now everybody says, no, it's very easy. Now it is easy to handle it. We just connect the machine, but then the loads are there. Like maybe simultaneously we might have 3 deliveries in the same level. We say at least connect for one patient and then one pregnant woman, and at least we can see. So now the learning. So it is just that as an officer, we need to keep monitoring, make them explain to them, and make them understand how useful this machine. So then they start working out. And then we also have the hemoglobinometers and the glucometers. It's just that kept at the labor room table. If any patient just walks in, you just see that the pregnant woman is just checked. At least you can prevent the postpartum hemorrhage or so many things, which is going to be after effect. So this kind of innovative technologies, I think that's very, very helpful. But then at the ground level, it's very, very important to impart the knowledge for them and to show how useful it is, the repeated trainings and then the outcomes, and to show them the casualties or the high risk, how much it has come down. So that would bring in a change.
Thank you so much, such valuable insights. And I think we've had a lot of conversations about cross-sectional assessments, a snapshot. But I think so many ways that you mentioned, I was thinking about prospectively capturing information over time on women. And where do you use women? It's like before pregnancy, before they come in, or just early in gestation, or when they leave the hospital in the postpartum period. How do you connect the dots and your data systems and integrating some of these with the snapshot goal setting ready for the activities?
If the time is permitted, it's just a 4 minutes presentation, which I have it. I would just show how the government has developed. Everybody thinks that the government hospitals are the remote hospitals or something like in a remote village or in just deep in the mountains where there is no access for the healthcare. But how much the changes the government is also working. It takes up the lead, like how as and when the changes come in, it also tries to develop such kind of a thing and then bring in a change to the system. But if the time permits or if it is allowed, maybe I would like to be proud about my own government institutions, how much it has changed. When it comes to a pregnant women, now even the ANC care, we have started at the doorstep when the ASHA workers first meets the pregnant women. Most of the pregnant women cannot go to the hospitals or anything. If she misses the period, she just waits, or she says, okay, well, nobody's there to take me to the hospital. Or she says, I am on daily wages and I would not be able to go to the hospital. So many things are there. So there are systems where the ASHA would have delivered a pregnancy kit to her house. So what happens if she checks in and then if it's negative, she's fine. If it's positive, she
walks into the hospital. So her registration starts at early pregnancy. So we encourage all the ASHA workers, and there are some incentives to give it to if she registers the early pregnancy. So all the problems are, everything is treated. Then gestational diabetes has also become a more common in the pregnancy. So we also have the OGTT, which we do it at the hospital at our first visit, and hemoglobin is done every routine, and basic test, which counseling and so many things are there. And then the awareness programs, there are so many NGOs and the government programs where they keep giving awareness when she's waiting in the ANC clinic area, when she's waiting for the doctors to get her turn. There are so many things in IEC materials which has been encouraged. But basic role is played by the ASHA. ASHA is the health worker who reaches and goes to her house, brings her when there is a problem. And then they have introduced a guestosis scoring system where even a receptionist, when they are in the entry, when they're sitting in the reception area, when they're doing the registration, they can just ask a few questions. And if the score is more than 3, then we know that it is high risk. Immediately, it is label is done as an high risk. And then we try to communicate to the mother saying that you need to be going to the maternity homes, or you are under the care of a gynecologist. So all those kind of awareness is done to prevent the high risk to have any casualties or mortality. So it's taken right from the beginning.
Thank you so much. So I have a couple of general questions for the overall panel that I'd like to invite folks on to please join us and ask questions that they want to touch on women's health and technology. And so this is a question for the panel. We can start with for that. We would love to hear. So, Portent, we're very interested in making the connections between the government, academic, private sector, the geo. How can Portent help to contribute to accelerate some of these partnerships, academic, public, private partnerships, to help scale up point of care technologies and diagnostics for real world impact, and in particular, to help improve the health of women and their families and communities that we serve?
I think PORTENT is playing a very important role because academic, government, and industry partnership is extremely important to making it available on a large scale. So there are emerging problems. We know that there are problems such as anemia and gestational diabetes, which is more common, preeclampsia. So these are the problems which are very, very important. But there are also other emerging problems. For example, polycystic ovary syndrome, which is becoming a common problem. So there are other issues such as heavy menstrual bleeding, which is one of the important causes of anemia, but neglected. Then non-communicable diseases are becoming a bigger problem because obesity is on rise, and non-communicable diseases like especially diabetes is like becoming a more common problem. So identifying solutions for early diagnosis, and diagnosis in itself is not enough. There has to be action based on this diagnosis. And I believe that technology has an important role, like decision support tools, which can help even the lower level health workers. Like every time it's not possible to access support from a specialist. So like these algorithms, clinical decisions algorithms, if they are linked and they are tested, I think that's something which will go a long way in not just diagnosing, but also like making appropriate healthcare accessible. So I think PORTENT has a big role in developing new technologies, testing it, and also making decisions for making the management easier.
Just one last I want to tell you is about high risk pregnancy. We also have a pilot project which is going on. It's just that a small bead or something which the mother wears it like a symbol or something like that, a small thread type of it, but it's called as the Shankar. So it's just a small bead. Which captures all her recordings of BP and pulse, fetal heart rate or anything which is going abnormal on her. So this is a thing which we monitor. There is a dashboard in the hospital. So when the patient comes, a 3 months recording of hers is been done. So we can detect the high risk pregnancies. And then we also have a phone call or messaging and say that you're due for your pregnancy checkup, and then you're at this one, you need to visit this hospital. And then if they also have a question as if the mother in the house, if she feels that fetal heart movement is slowed down, or she's not able to feed, or if she's feeling something like a kidney or anything, she can type in the questions, or she can ask in a voice message, and then the answers are given to it. So that's kind of a thing, so that the mother is reached at the thing. And then one more innovative which the government has done is the smart clinic, which we have it in all the PHCs. PHCs, this is a basic 9 to 4 working centers. So a smart clinic with a dashboard and a staff nurse working. So if something is detected like a dermatology, ENT, or even a cardiac thing, we have the specialist who can come in online, and they can show in the reports or something, and then have to one-to-one discussions, and they can get the point. I mean, this thing, the treatment part of it. So that way it is also good.
Good comment from startup or industry, and this has been one of the discussions, very active discussion these days. Is one, see, for example, for a startup having complete design team in place, what was mentioned, it's very important that whatever we design, instead of then solving the problem prospectively, if we are able to identify better design early, keeping patient at the center, I think Potent can, and one of the question I had for you was, do you offer services to the startups? Because if center has built this capacity, definitely startups do need such services, and Potent can contribute definitely on that. The second one is clinical validation. I think one of the struggle for technology innovators, and innovators can come from any background, not necessarily understanding the depth of clinical validation. And when you are instituted in a medical facility, I think it becomes a very high value, contribution for overall industry and academia both, by the way, because let's take an example of technological institution, which has a good understanding of technology, but doesn't understand how clinical validations are done. During my PhD, I struggled a lot to get one IC approval. So you can imagine that if the program has the proper spectrum of people who can guide on all the groups, I think that becomes a huge value for any innovator or even industry for that matter in designing their experiment, designing their studies, and bringing that product which is now gone through a proper process. In healthcare, I think performance and quality isn't an option. So it has larger value beyond just innovating, but also helping other academic and industry or even product partners to evaluate innovations.
So I have several more questions, but I think that's actually a nice transition to the audience. I would like to put it back to you all. How can PORTENT help play a role in facilitating academic, government, and private sector partnerships through this collaboration and session moving forward? I'm very happy to take any questions. I don't members of the panel. It's time.
This is really important. So thank you. With all the experience you have, advice can you give the West trying to innovate some brain to what advice can you give me?
This is coming from some experience of working with people not only as well and trying to design innovations. I think it's not about, so there are two ways that you can contribute, right? You have a breakthrough technology where you solve a very important scientific problem. Like let's take an example, which is the debatable issue of SPO. We built best SPO2 measurement system, which scientifically correct. But we know that it's just designing that breakthrough will not help in what context it is getting utilized. And this is not just for India, but any different geographies. What is the value chain that it links with? And does this technology fits into those value chain? And one great example, or rather very simple example is, are you designing for high throughput, high performance, or are you designing for low throughput, high performance? And what I mean is basically if you are designing for a larger facility where there is a huge patient load, or you designing for a primary health facility where the user is not necessarily highly skilled as a best. But so where you are going to put that. Now, imagine this, that you designed a very good technology, but wasn't designed for this. I think the contextuality of who is the user and where it will be used with the healthcare delivery system becomes important. And I would say for designing of the solution, that will be very
Just one more extra sentence is designing when we feel the West people itself is just like a software or an equipment which has come ready-made. But then if it's of no use to the place, then it is of no use at all. So first is to study the place, the hospital, or wherever you are going to give the ground level, whether it's going to be useful, whether it is approachable, it is same. Because even the genetry machine which we use in the labor room, maybe it came out as a first hand as with so many technologies and so many things. And then every time the staff nurse, because in our thing, we do not have a person to enter all the time. It's only the midwife after 4 o'clock or in the night duties or something. Then she found it very difficult to enter so many things into the system and then to utilize the machine. Then we sat with the software people and then we said, this is what exactly what we wanted and this is what the changes we wanted. And we simplified. So it is timely once you develop the software also, it's timely changes which gets adapted to that system. So till it is user friendly, I think we need to work for it and then do it. But then just delivering the machine or a software for this kind of a design, because initially when you design it also, then it might take so many years to get it changed and get to adapt it. And then by then, I think that the new machine itself it comes. But then it should be one-to-one and then to understand the reality.
I'd like to direct this question to both Dr. Bharati and Shobha. One of the things we're talking about design and co-designing with the government as well as with the end users. Is there a concept of creating health innovation hubs in the communities? Because I understand it's very busy to actually intervene in a health setting which is dealing with a large load, but can we have the concept of having digital health innovation hubs which are scattered amongst, let's say, sub-centers across the country? Is that a concept which is feasible?
I think this has to be taken up, and now before we installing having this the project for bringing down the high risk pregnancy, we had several meetings with the commissioner, with we doing it research at the ground level. Then we brought in the changes, and then so many things. So I think without this, it will not move forward, and I think we need to have it at the ground level.
Yeah, I think it's a very useful concept, and that will be something which we can do at most the medical colleges, as well as there are these centers called MRHRU. I'm just thinking aloud here that ICMR wants to promote research in the rural areas, and that's why these model rural health research centers have been established as a network across the country. I see a very good opportunity there because they are directly in connection with the community as well as the sub-centers and primary health centers. So there can be an opportunity to have the circulation.
So thank you. This is very useful. And congratulations. I think uh, you know, primary charity is one of the things we cannot ignore. And yet we have opportunity that we know very well to support. And so this made me Dr. Pathak's question. One of the things that disturbs us a lot is complexity, and it's a big problem. It's complex and it's multifaceted. And I was impressed by the ability to deal with this in multiple levels. But I know that complexity required you to select and people in making those decisions fast enough to design and deliver. Kind of just talk to us about that design process, because I can imagine people struggling with the complexity, and it's very easy to say, just do it a little bit and I'll leave the others to someone else, but put everything.
Um, it's a tough question, but honestly, these are learnings that we went with hard lessons. One, our assumptions is I think one of the biggest problem that we start with what we want to solve. And again, our limited interactions with set of people defines what they need. In the healthcare delivery system, while you select a particular problem statement, let me take an example of labor and burden as a component or fetal mounting as a component. You start with, okay, can the machine be used fluidly? And as ma'am mentioned, can a nurse use it in a more simplistic manner? The second question that you get is, can this be used in the remotest setting? And if it has to function there, what is required? And then if you want to build an auto interpretation or, triaging system, but you give an alarm and alert. Now, if a fetal monitoring system is being used at primary health center or even at the last health center, if you give an alert also, is there a support system that is available to act on it? But if she's not able to act on it, there's no value of giving alert. So technology solves one problem, but does not necessarily address it all. So while selecting the problem statement, yes, there are certain time biases because, as you rightly said, we have to act on delivering those innovations also. We can't be waiting for a system level change to happen to act on the one. So many times we go with the area where there is also a supporting ecosystem. And I think one of the best learning for me was mapping out the whole value chain and see that if you act on this point, are there components which are also supporting that intervention? And then I saw the increase in the utility of the solution and demonstration of impact. The downside of this approach is you are not necessarily solving the first priority of the system, but it's a complex issue, and you may play a small role in that, and you are still dependent on all other factors. So it's a choice that you have to make, and that's what day to day we also do.
So I see we have a couple more questions. We are at time. So I think Tony, I need to get that prepared. We can take one more. David, please.
Thank you so much for this really illuminating talk. So we're, as was mentioned, times important to focus on between nutrition, and the one of those that we have the hardest time attracting quality projects broadly is in nutrition. And I think the reason for that is the sort of expertise on the engineering side isn't as deep. At least amongst the innovators we engage with. Nutrition side isn't as sense. So part of what we want to do is crowding as part of our outreach is inspire isn't nutrition. So I wonder, as part of that mission, maybe you could help inspire us. So that are the nutrition. What are the things? What are the most important things? What should we be thinking?
Thank you for this question. I think some of the most important problems, one of the most important problems where people are already working is anemia, which includes diagnosis of hemoglobin, including non-invasive devices or minimally invasive devices. And going towards causes of anemia, ferritin, as well as other micronutrient deficiencies. So that is one big chunk of work. Second, I would say gestational diabetes is extremely important because it impacts the newborn and like life ahead for the newborn. So I would also think that one of the important reasons because we have the countries like India, which are transitioning as the very important issue to deal is the double burden of malnutrition. We have undernutrition in childhood and overnutrition in adolescents and adults is becoming a big problem. And the crux of the story is the low muscle mass and low lean body mass and high body fat. So if we have devices where body fat percentage will be estimated and if it is when starting from an early age when children can be motivated, have healthy habits. I think that those are some of the areas which will have that system.
In my experience of with the pregnant women, it's almost 27 years in BBMP. So what I feel it is the nutrition plays a lot of role than the medicines or the advices or anything, because most of them will come as a malnourished and then they will not follow the advices and preeclampsia. The four major things which we noticed even yesterday, I had an audit and what we noticed was the preterm deliveries, then preeclampsia, that is, I mean, pregnancy induced hypertension because lack of calcium or something which plays a role. So I think that one and the anemia is coming into a control because of the methods which we have, the non-invasive methods of screening, and then anemia has taken a lot of improvement. Whereas now PIH and preterm deliveries and thing. So there where we require is lot of nutrition counseling, iron and folic acid and calcium, which is to be taken during pregnancy, all that. But so I feel I give more importance as to the nutrition. So that development and that counseling and which is made and adequate to the pregnant women, I think a lot of mortality also can be brought down.
Perfect. I think that's a wonderful way to leave. So we'll wrap up this session. Please join me in thanking these incredible experts for their time and expertise. It's a really exciting panel. Thank you all so much for joining. And I believe we are transitioning in just a few moments to a group picture, if I'm not mistaken. So hopefully we can continue these conversations into lunch. Thank you so much.
Thank you, Dr. Julia, Dr. Bharati, Dr. Shobha, Dr. Shantanu. Thank you. I now request Dr. Albert Go to come on stage and felicitate our esteemed moderator and speakers.